you, Senior. Very good afternoon to all. Happy to see you again. As Senior said, today we are going to talk about delirium. This is one of the most common symptom in palliative care. Most of the delirium we can reverse except in stage delirium. So this session will be taken by Stella. She is one of the senior most person in this field and well-versed person in this field, and she has already taken a session for us communication. I think we all.
Your voice is.
But now.
I think. Can you please speak once again?
What about now?
It's okay now.
So, a very good afternoon to all. Happy to see you again. As Senior said, today we are going to learn about delirium. So this is one of the most common symptom in palliative care, especially if we do the proper assessment, we can most of the delirium we can manage, especially except in stage delirium. So this session will be taken by Stella ma'am. I already told about her. She is a well-versed person in this field and experienced person in this field. She has already taken a class for us. We all know her. Ma'am, welcome back and over to you.
Thank you, Shiva. Nice seeing you. I'll just share my PPT. So, good afternoon to all the participants, and of course, welcome to Senior also. So today we are going to have delirium. Just before starting, I would just like to ask the participants, can you just tell me what is delirium? And have you seen people with delirious stage in your experience? So you all must be mostly working people.
Ma'am?
Yes.
Yes, good afternoon.
Good afternoon.
Yeah, when I was sick, I had some acute abdomen and I was admitted in MICU, medical ICU. And at that time, my husband was saying, okay, you were talking some irrelevant.
Okay.
Yeah. So my mind was disturbed with the pain.
Oh, with the pain. Yeah. Good.
Yeah.
Anyone else? I think confusion and diffused awareness. Yeah. Yeah. Okay. So you must be having roughly an idea what is delirium. As she said, that sister said, when she was admitted in ICU, she was delirious, and her husband has noticed this, and he said that she was talking irrelevantly and behaving something. Okay. So let us see what is delirium. So delirium. It's a neuropsychiatric syndrome, if we say. And of course, it is common or acute or serious. But the most important thing is often the diagnosis is missed. There will be misdiagnosis, especially with the elderly people and towards the end of life. So misdiagnosis there, and because of the misdiagnosis, usually they will have a mismanagement. That becomes very problematic. So a proper, as Shiva said, a proper assessment guides us to give a proper treatment, otherwise proper management. And with the appropriate management, we can tackle the symptom. That is very important. I don't know what happened. My slides have gone this and that. Anyhow, so delirium, we will think of two things, that is hyperactive and hyperactive. And in some cases, there are some fluctuations also. In hyperactive, if you say, there will be confusion, agitation, hallucinations, and myoclonus jerks. But if you come to a hypoactive, see, in itself, there is that answer, hypoactive, not active. Confusion will be there, but very slow, withdrawn. And many times, this gets fluctuations also will be there. There will be a mixed one. But in hyperactive, less likely to be diagnosed. Mostly in hyperactive, what happens is the diagnosis won't be the proper. Hyperactive still, because once a person is confused, agitated, running here or there, pulling this one and that, okay, talking irrelevant, okay. So people may think something is wrong with him, they may do something. But in hyperactive, what? Very silent features. So we won't diagnose it. So what happens is there will be altered level of our consciousness, altered level of our cognition, and inability to hold the attention. These all things can happen. See, when we are conscious on what we are talking, and we are not in our conscious and we are talking irrelevant, it makes a lot of difference. People start thinking that we have become mad. We have some psychiatric problems. But maybe with a small problem, with a proper diagnosis, we can revert it. So we need to have a proper assessment so that an early diagnosis is made, identify the cause. We can give prompt management because it is an emergency and associated with mortality. So if we have to do an early diagnosis, a proper assessment is very important. We cannot just see the patient and start doing anything. No. Assess it properly. We need to have a lot of questions to find out the cause. We may need to do a physical examination. Then only we can give a prompt management, because patient is not in a situation to tell you what is happening. Okay. But of course, the family can tell you what has happened. If suppose the patient already is diagnosed with some disease, illness, with that, many other things they will add up. So then there we will come to know actually what is the cause. So there is a disturbance in attention and awareness. The abrupt onset will be abrupt with fluctuation in severity of the symptoms. Changes in cognition, that is not oriented to the place where they are. I am in my own house and I am not oriented. Perception, interpretation, and memory, this all will be interrupted. And this is not better explained in terms of other neurocognitive disorder. So evidence of medical condition judged to be etiologically related to disturbances. If like a patient is having a brain tumor, maybe the patient will become delirious. So in such conditions, we need to find out whether there is any medical underlying condition. What is DSM-5 is a manual for assessment and diagnosis of mental disorders and does not include information or guidelines for treatment of any disorder. It's just for the assessment and diagnosis of a mental disorder. Okay. And the accurate diagnosis is the first step towards being able to appropriately treat, as I said. If we assess properly, we can diagnose properly. And if we diagnose properly, we can treat properly. And that is very important. You can see hyperactive person will jump off from the rails and all, agitated, confused, They may even hurt us sometimes. They will run away, open the door, they may run, they may meet with accidents if we don't look at them properly. They can do anything. My hyperactive, you see, they'll be very silent. Confusion will be there, but will be more of silent. I always, one case, only one, what should I say? I have encountered one case. I was working in ICU, as that sister said, I was working in ICU. It was night, about around somewhere about 1:30, where everything used to be very silent. In head injury, I was working. We have already about 6 to 8 beds. Suddenly, I can see that towards the end of this rest, almost all the patients were in the ventilator except for one patient. That patient was on observation. Okay. I don't know. Suddenly, he got up from the bed, jumped out of the rails. So I just went to hold him. He pushed him. He pushed me like anything. Thank God the fridge was behind, the refrigerator was there. I just went and hit that fridge. I was standing like this. By the time he has opened the ICU door and he went out. And thankfully, in trauma care unit outside, mostly all the family members will be there. Okay. So then I took my courage. I ran and opened the door. I just shouted because I was trying to call the people and a casualty was down. Madam, these people all came. Someone went and held him like this tightly. And they brought him inside. Madam, then I called the doctor. Okay, he was delirious. He was not knowing where he was actually. Then injection was given. He went on. Next day when he got up, actually was not knowing what has happened with him. So in ICUs, this can happen. So let us see something. Delirium, dementia, depression. These three things more or less goes side by side. Delirium, usually the onset is acute, hours to days. And if you see, the course is very fluctuating. It may be, duration may be hours to weeks. Consciousness may be altered. Attention will be impaired. Psychomotor changes increased or decreased. And reversibility usually good if it's properly managed. But when you can see in dementia and depression, it almost goes in the same way. If delirium is acute, dementia is insidious, months to years. Okay, there is a slow progress is there, and the family will give you a history also. Previously, he used to forget about the things. Okay, take a depression, it is from week to months again. In dementia, it is progressive. Slowly, it progresses. Okay, but in delirium, it is fluctuating. And in depression, it may be a chronic one since long. When you talk about this one, duration of this one delirium, it is hours to weeks. It can go. Dementia from months to years. And same with depression also, months to years. You all must have come across dementia, Alzheimer's patients, depressed patients and all. Here, when we talk about the consciousness, usually the consciousness here in delirium is altered. But in dementia patient, the consciousness is clear. And of course, in depression also, the consciousness is clear. Attention is impaired in delirium. But in dementia, you see normal, except in severe dementia. We can read dementia, Alzheimer's, and there is no, it is impaired. And in depression, maybe decreased attention. And psychomotor changes, if we say, it is normally or normal, often normal in dementia, maybe slow in severe cases of depression. But in psychomotor changes in delirium, it is increased or decreased. And of course, delirium is irreversible. Sorry, delirium is usually reversible, but dementia is irreversible, and depression usually it is reversible. It is if properly treated, and they have to continue with the treatment. These are the things. So remember one thing, whenever a patient is coming with some problems like confused, agitated, otherwise irrelevant, incoherent, there is no attention. Please diagnose. Diagnosis is very important. We have to find out whether it is a depression, dementia, or delirium. So these are the, what is the risk factors? Delirious patients pose a potential medico-legal risk. Informed consent has to be taken. Risk to escape. Due to aggressive behavior, they may hurt us. Anything can happen to the other person. Okay. And risk for false or self-injury is also very important, because, as I said, the patient jumped out of the rails. Maybe he must have landed not properly, must have hit his head again. Anything can happen. Okay, risk of escape. Yeah, this has happened with me again. One of the head injury patient was there in the ward. It was more than almost 50, 70, 80 patients. So I was only one nurse. I was taking care. Suddenly, that patient also wasn't destitute also. The next bed family member came and told me that patient is not on the bed. So I went and saw the patient was not on the bed. Search, I couldn't find him. Then I have to give a police write and send it, the information that this patient is abandoned from the hospital. And you won't believe, after 1 week, they got that patient. He was lying in a drain. Okay, it was a drain. And he had met with an accident, I think, or he had fallen inside that drainage, and they brought him in the hospital, and he was there for hardly about 2 or 3 days. Okay, so these things can also happen. Risk of escape. Sometimes they will escape from this place. They will go and do something with others like this, if they're having aggressive behavior also with that. Okay, so anything can happen. So we have to be very careful. Whenever such a patient comes, better to inform the family member also that the patient is at risk. These are the things what has happened. For our safety, it is very good. So the clinical features, when you talk, poor concentration, they cannot concentrate. Impairment of short-term to term memory. Okay, that short term, what has happened, they won't remember. Disorientation will be the misinterpretations, paranoid delusions, hallucination, rambling, incoherent speech, agitation, and noisy and aggressive behavior. Okay, they'll say someone has come over there, they are calling me. Okay, hearing some voices, they can see many things over there. They may say someone has coming hitting. Many things can happen. And even the speech also, we won't be able to understand. Maybe you are the person who are looking after that person, may ask, who are you? Why are you standing here? You go. Sometimes they will push you, they will go out also. And where am I? Why I am here? Who brought me here? See, they won't be able to understand, or they are not able to memorize where they are actually. So early signs often mistaken as anxiety, depression, psychosis, and dementia. That is a problem, as I said, delirium, dementia, and depression. Many times it happens, we'll make it a wrong diagnosis. Diagnosis will be wrong because we mistake it for anxiety sometimes depression, sometimes dementia or psychosis. So that's why I said that the proper assessment and diagnosis very important to do any intervention. So in delirium, impaired memory, in dementia also it is there, impaired judgment. See, in dementia also impaired judgment is there. Impaired thinking is there in delirium. Here also the impaired thinking is there. Impaired abstract thinking and cortical function, and disorientation, both there is disorientation. So it's very difficult sometimes. Abrupt onset, but this is slow onset. Decreased level of consciousness, but in dementia, the level of consciousness is intact. Sleep-wake cycle affected, but here dementia, minimal variation only. And delirium is reversible, dementia is irreversible, except for in terminal delirium. It is not reversible. So delirium impact on patients, family, and healthcare team. It affects 28% to 83%. It affects the patient also, the family also, and the healthcare team also. Because we don't know what happened. We also will get scared. Now, can you imagine doing night duty at 1:30, somebody is pushing you and running away? It's reversible in 50%, it is, and affects the quality of life. Delirium always affects the quality of life of the patient and the family, because neighborhood all will be talking. If it is in the hospital, the other patient's family, they may look at these people. So it affects the quality of life also and increases morbidity and hospital stay. So diagnosis and management difficult and escalate distress. So what are the complications? Functional decline. They may fall, incontinence will be there, physical and chemical restraint we may have to do. Here in ICU Central, when you are alone, patients in 6 or 7 patients in some patients in ventilator, already very agitated. Who will look after all these patients? Patients all have been tied and kept. Otherwise, they'll remove. I remember one patient, we put this one CVP, he removed the CVP. Then we put an IV line, he removed the IV line. And the IV was going and he was drinking the IV fluid when I saw. So sometimes it becomes very difficult that the patient will be tied up. Failure to maintain adequate hydration, that is another problem, because they are not in a proper consciousness. We won't be able to make them to eat or drink properly. As I said, we started the IV fluid. Suddenly I can see the doctor telling me, please turn and see. I was doing something for one of the patients. I went and told him he's nicely drinking normal saline. And one side, it started also bleeding. So it's very difficult to handle such cases. And failure to maintain adequate hydration. How we will maintain the hydration if the patient is not taking orally? Prolonged hospital stay and emotional burden to everyone. For the patient also, the family also, the caring team also, and at times death also. Because if you are not properly managed, the patient may die also. Escaping from the hospital, patient may die. So these are the complications which we will come across. So if we tell the causes, primary, secondary, if you say, tumors, any vascular events or infections can cause. And metabolic, more of electrolyte imbalance. Severe hypertension, metabolic causes. Electrolyte imbalance is one of the things we have to remember. Infection can cause, anemia can cause, and any metabolic primary organ failure also can cause delirium. But a very important thing which causes that will come now, hypothyroidism, alcoholic agents, steroids, opioids, anticholinergics, benzodiazepine, phenothiazines, antiviral drugs. This all can cause delirium. And the predisposing factor, as she said, pain, urinary retention, fecal impaction, anxiety, fear, old age. Very simple. If you know the patient is having severe pain, if you assess properly, if the patient is having severe pain, and the patient may go for delirium. You take a second thing, urinary retention. Your bladder is full, not able to pass urine. You will be in delirium. And we have come across patients like that, being brought to the hospital, and when we saw, it's like a ball. A patient is delirious. With that, fecal impaction also. So we need to find out why. What is the actual cause? So that's what I said. A physical examination, wound, pressure ulcer, patient will be delirious. Suppose you know the patient is in opioids, drugs, maybe due to opioid, especially morphine and all, patient may become delirious. So assessment, what medications patient is taking, what is the diagnosis of the patient, actual diagnosis means the actual first diagnosis of the patient, primary diagnosis of any disease. Diabetic patients you take, sudden hypoglycemia, patient will become delirious. If salt reduces, patient becomes delirious. If the patient, like this, the patient is in this one, diuretics, okay. You have to, and the patient comes in delirium, just find out what medication the patient is taking. Even patient who is taking diuretics can go for delirium because they lose a lot of sodium. So we have to find out what is the actual cause. Means assessment is very important. As a nurse, your main thing is that you have to assess and give a clinical diagnosis. Find out the cause. That is very important. Just ask the family member whether the patient was taking food properly. If the patient is on rice tube, one main cause, okay. Patient is on rice tube, sometimes they forget to put salt in their food, feeding. This can cause delirium. So if there is no restriction, we need to tell the family member, whenever you're giving a rice tube feeding, please see that put some salt in 1 or 2 of the feeds. That is another problem. Anxiety and fear. Not familiar with the place where I am. That also will cause delirium. And of course, in old age. So up to 75% patient advanced and terminal illness will be in delirious. Especially in the end stages, they become delirious. So drugs and management, examination in hallucination zone down. We have to manage with the drugs. Raised intracranial pressure, as I said, big tumor is the patient will be delirious, and infection and dehydration. Yeah, hypoxia, that is another thing. Hypoxia can cause delirium. I know one of the patient, sudden patient, already diabetic patient, went for hypoxia and she started talking irrelevant. And we rushed to the hospital. Oxygen was given, IV, everything was put, and after some time, slowly she came back. And when she came back to her conscious, she asked, why I am here? This is this place. And when it was told to her that you are in the hospital, she asked, why I'm in the hospital? Why not in the house? It becomes very difficult sometimes because they think, why they brought me to the hospital? Withdrawal symptoms from alcohol. And this one, spiritual or emotional anguish, unfinished business, anxiety. A person who is in a in a life-threatening illness, he knows that he is having cancer and soon he will die, but he has not done anything for his house. His children are still studying. There is no proper house. A lot of things has to be done before he goes. So he will be anxious. This also can cause delirium. This side you can see, this one, it's very important. Change of environment. Especially the patients who are kept in ICU for observation, they can cause. And second thing is too hot, too cold, wet bed, crumbs in bed, and creases in sheets. This also can cause delirium, especially in elderly people. elderly people, if something is in the bed, any crumbs or are bedridden also, they are not able to tell you properly. This can cause delirium. I will just tell you an example. In our own bed, when we lie down, okay, at times, if something has fallen on the bed or under the bed sheet, the night while we are sleeping, somehow we won't get proper sleep. We will feel something is there. So late night also, if it is there, we'll put the light and we will try to find out what it is. Even though we are not delirious, we won't be able to sleep properly. Now this is summer season. Okay. Are you able to sleep properly in this summer season? It's very hot. How many times we move on the bed? At least we are able to move. What about a bedridden patient? A person who cannot move. Patient has already incontinence of urine, past urine and lying on that urine. So this also can cause delirium. Or like predisposing causes, these all are. So bedside clinical judgment is very important. Frequent assessments daily at different times. And of course, the night time, if something has happened, we often miss it. So how? Bedside clinical judgment in the sense, if you know the patient already very well, the patient's diagnosis, have to be with the family and find out what exactly has happened with the patient. Then go for a physical examination. Just have a look on the patient's body, on the bed. While you are doing a physical examination, with that you can ask the family member whether the patient had some food or not. What was his intake of his both, fluids and his food? What he has eaten. Since how many days he's not eating properly? If your patient is on Riles tube, what they are giving through the NGT. And this assessment should be like daily at different times. This should happen. Maybe in the morning, evening, night. Why night? Many times, if the patient becomes delirious in the night, because they become fear also, anxiety can cause, okay. Patient is all alone in the room. Nobody is lying down. It is dark. Patient will become delirious. So assessment should be on different times, maybe in the daily, morning, afternoon, evening, night. Take the history from the caregivers or the family members. And don't forget to ask one thing, who is sleeping with the patient? I mean, sleeping in the sense, who is there with the patient in the same room? Because they can give you the proper history. There are a lot of assessment tools. You can just Google and see what these are the assessment tools. Like confusion assessment methods are the Delirium rating scale is there. Other assessment scales are there. These are some of the assessment tools. But one thing, when a patient comes in that stage, it's an emergency. We won't be able to go through all these assessment tools. Okay. So if you by heart some things, what you have to ask the patient and the family, it will be better. Okay. So investigation, I told, assess the need. If there is a need, only do the investigation. So as I said, if the patient is diabetic and the family is saying, yeah, patient is diabetic and he has not taken food, of course, you can draw a blood, send for not only for RBS, you can send for electrolyte also, so that you can get a diagnosis. Investigate only to support clinical diagnosis and management. So if I tell in palliative care, mostly it is hyponatremia or hypoglycemia, many times. Yeah, sometimes it is about a wound due to pain, it has happened. Sometimes the retention of urine or fecal impaction, this has happened. Morphine also. Some of the things what I have seen, I'm trying to share with you. So for clinical diagnosis only, try to do an investigation. If you know all the patient is a brain tumor patient, maybe the patient will become delirium. Patient may become delirium. So no need of going for an MRI. But if the family says patient has not taken food properly since past 2-3 days, go for a electrolyte imbalance, 1 RBS, you can do it. Even HB also you can do in some patients. And avoid investigation in terminal stages. If the patient is terminally ill, please don't do any investigations. Urine routine examinations you can do, and as it is written, CT head if only required. Remember that one thing, unnecessarily don't do any investigations for the patient. So principles of management, pharmacological measures, general measures and pharmacological measures are the. So usually the awareness and the clinical judgment is very important. Etiological oriented interventions, we have whatever the cause is there, according to that we have to do the interventions. Antipsychotics, benzodiazepine, terminal sedation. Terminal sedation, usually when the patient is in terminal stages and patient is very agitated, confused, where the family is standing and watching these things, we can sedate the patient so that the patient will be calm. Okay, so we'll come to this one. First, the general measures is stop offending treatment or treat that cause and the cause. Suppose offending treatment, if I say, like even if the patient is after taking morphine, patient is having delirium, you have to stop the medications. Maybe the dose is high, means then we have to reduce. But at first we have to see. We may stop the medication, see what is really happening, and then we can see what alternate we can give. Correct method. Even in patients who are bedridden, stroke patients, otherwise in a hypertension patients where laxatives must have been started, diuretic must have been started for that when the patient had a high blood pressure. And some patients still continuing with the medication. So we need to find out whether actually the patient needs laxative at present. If the patient doesn't need, we have to stop it. So for any offending drugs treatment we are doing it, please better stop it. Another thing, when you are doing it, this one, what to say, assessment. Okay, just take the patient's, this one, the medication book, prescription, whatever is there, okay, and just go through everything. We have to see, because patient must have come to you, you must have started laxative, diuretic. Patient goes to any other hospital, they will start one diuretic. Patient will take all these diuretics and finally will go for delirium because of hyponatremia. So when you come across a patient, please ask them to give you all the reports and all the papers which they have shown in the hospital. Whichever hospital they have got, just take it and go through. What are the medication patient is taking? Whether the patient is taking the same medications and the patient doesn't know that patient is taking the same medicine more than one time. So just go through the medications. Then correct any metabolic abnormalities that, as I said, hyponatremia, hypoglycemia, anemic patients. If something is there, please do correct it. In some emergency cases, before reaching the hospital, sometimes we mix sugar and make them to drink, dilute nicely salt and make them to drink in water or in lemon, whatever is available. Because it's very difficult sometimes. I remember a patient, daughter who called me somewhere in a remote place. They called me and she was saying, I don't know what happened to my papa. He's talking irrelevant. He's bedridden, but talking irrelevant. I don't know what to do. Can you send someone? So then I just asked her, I said, just tell me the registration number. She told me the registration number. I took the case sheet. I just went through the case sheet and I could find out that patient was a stroke patient also. And patient was on diuretics also. Okay. Then I slowly went and then I saw this one. Then I asked her, just tell me what all you're giving to your papa. Then she told me these are the medications what I am giving. Okay. So usually who is giving the medications? Okay. Usually her mother used to give her medication. That day she was the only at home. So she doesn't know whether mother has given her medication or not. And if she gave the medication, maybe it has doubled. So I said, I can do only one thing now at present till the home care team reaches you. Otherwise, you have to bring the patient to the hospital. And she said, I am all alone. I cannot leave my papa and or bring him to the hospital and send to the palliative care. So I said, do one thing. If there is, we say kanji water, okay, the rice water. If I said there is kanji water or water, lemon, anything, put some salt, nicely mix it and make him to drink, I said. Okay, that only she was able to do and that only I could do from here. Then meanwhile, I tried to contact our home care team and they were little far. They said, anyway, they'll go over there. So by the time it took about 2-3 hours, it took for them to reach over there. Anyhow, it was tackled. Okay, somehow it was managed with that salt and then the patient was brought to the hospital. That is something else. Structures setting with a quiet room, low voltage light, calendar and clock, encourage visit by friends and relatives. Now, what is the structured setting? A patient who is ill, and 2-3 things in that case, okay, elderly patients, terminal patients, okay, and especially this long-term bedridden patients, see that the room is very quiet. A low voltage light should be there in the room. It should not be pitch dark. A light should be there. A calendar and a clock to see the time and the date, the month, the year. These all are predisposing factors for delay. You have to teach the family member. This is very important. I still remember see, now I am retired. Okay, when I was on working, I know Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday is off. Next day starts Monday. So daily, because I have to go, I have to sign, I have to take the books, I have to see everything. Okay. Now, because I am at home, many times I forget which is Monday, which is Tuesday. Really, now because thankfully the this one mobile is there, then I will just open the mobile, look at this. Oh, today is Tuesday, March. Like yesterday, Sinia, she has said, ma'am, tomorrow is your session. I thought, my God, tomorrow is my session. Then I remember, oh my God, today is Monday, tomorrow is Tuesday. Okay. So even the patients, when they are in the room in COVID time, there were many times we forgot to see even the calendar. So we can just think about the patients. They don't know even the time also. Sometimes they just look out and they say, okay, maybe it is evening in the morning. And the patient who is inside the room with closed windows, you won't be knowing what is happening outside. Whether it is day, night, raining, sunny, nothing. This all can cause delirium. And please ask the patients, tell the patient's family, ask them to not to stop the relatives and friends who come to visit the patient. Encourage them. Let the relatives, let the friends come and talk to the patient. 24/7, the patient is inside the room without no one. He needs to talk to someone. Just lying down like this, thinking only, they'll become delirium. No need of any disease. This itself will cause delirium. Less physical restraints and early mobilization. When the patient is very delirious, as I said, I told you, we had to, but once the patient is out, remove it and make the patient to walk. Care of bladder, bowel, and pressure ulcers, that is very important. Ulcer, patient is having a wound and it is paining. Please do manage that ulcer without pain. If you are doing a dressing to a patient, see that you don't pain the patient. Something should be given for the patient to reduce his pain. If the bladder is full, put a simple catheter and remove the urine. Teach the family member to see how to diagnose a retention of urine. You can tell them, just keep your hand and see if the bladder is full. Bowel. Fecal impaction can cause delirium. You have to tell them. If the patient is not passing motion, it's very difficult. So give them the laxatives properly, and the daily bowel movement is very important. Address fear and anxiety of the patient. Maintain adequate hydration, especially in bedridden patients and NGT feed patients. Maintain adequate hydration. Ensure family support, proper explanation to the family caregivers. That is very important. Why? Family doesn't know what has happened with the patient. Patient was given morphine, and the very next day by afternoon, son came with the mother saying that she's talking irrelevantly. So we just took the case, the patient was started on morphine. So when we asked, yeah, it was of course because of morphine. So we had to explain to him. So thankfully, here in palliative care, do explain to the patient when we give the medication itself, we tell them, these will be the problems. There will be constipation. Patient may sometimes have retention of urine, itching. So these things we need to tell them so that whenever they face some problem, they know why it has happened. Second thing, a patient whom you have started on NGT tube, as I said, please talk to them about these things, about the hyponatremia, hypoglycemia and all. Proper feeds, how much they have to give, what should be the feeds, and these things we have to explain to them. Keeping the bed clean without any creases, wrinkles, and crumbs. It should not be wet. If the patient is having incontinence of urine, put an indwelling catheter. So these things has to be taught to the family member, especially when the patient had a delirium. Why this has happened, that is very important. Many times they feel the patient has been having some psychiatric problem. So we need to explain to them why this has happened. It is just because of the sugar has gone down, or the salt has gone down, sodium has gone down. Otherwise, due to retention of urine. Otherwise, the patient is having a brain tumor, and that is why the patient is delirious. Patient is in terminal state, that is the patient is delirious. We need to explain to them the causes of delirium. Why this happened with this patient, and what was the cause, and how we are going to address it. So antipsychotics, haloperidol. Haloperidol is the drug of choice that usually we give. Okay. So dose and all, I'm not going to tell you, because usually doctors write the dose and then we give. So haloperidol is the drug of choice, and others like olnozapine is there, resiperidone is there, quetiapine is there, benzodiazepine, midazoline, indicated when there is agitation, especially when the patient is in terminal stages and patient is agitated also we give. Otherwise also agitated, then we can use midazoline subcutaneously. So in the mild cases, haloperidol. In all mild, moderate, and severe, we give haloperidol. But in moderate cases and in severe cases, we do give midazolam also to the patient with haloperidol so that the patient will be calm. Now, open communication, active listening, meaning to the symptom, validate emotion, explain the management. Now we will come to this. This is very important. We need to talk to the family member and the patient, open communication. Once this has happened, patient feels that something has happened. I don't know, but what? We need to tell the patient and the family, because of this cause, you were delirious. You're not mad. You lost your consciousness for some time. He may ask you many things, many questions. So you need to answer to that questions. Maybe the patient heard the family member saying he has torn his this one clothing, he ran naked, you opened the door, many things. So after listening, that patient may feel bad about it. So listen to the patient. That open communication should be done. And address and tell him, ask them what does they give the meaning to that symptom, and exactly what was the symptom and what it is we have to explain to them. And validate their emotions. They may become angry or they start crying, feel sad. You have to acknowledge their emotion. Explain the management also, what we have done for the patients. And of course, elicit and respond to the concerns and needs of the family and the patient, acknowledge emotions, clear information involvement in the management. We had a patient in the cancer ward, not in palliative care. They had come down for pain management. We managed the pain and the patient was sent. And of course, this one with morphine, patient had a sudden, became delirious. He ran in the night, he tried to open the door. They were in a private room. He tried to open the door. So wife was not knowing what has happened. She also ran back of him, tried to hold him. He pulled her, he pushed her, okay. And he removed his clothing, everything. Then she shouted and she somehow managed to open the door, and son was there outside. They came, and by the time doctor came, nurse came, everything was managed, okay. The next day when the patient was sent to palliative care, she was so emotional, that wife. She told me, I don't know what happened in the night. He was behaving very badly. Already cancer, maybe now he's become psychiatric also. So I had to sit next to the family member, that wife. Then I started talking to her, told her actually what has happened, explained to her everything, and then she became calm. Meanwhile, what happened? This patient was feeling something went wrong in the night, because not only his wife, son also was there inside when he got up, actually when he came to consciousness. So usually only one person will be allowed up. Okay, so, and when next time when the doctor and the nurse, they asked him, okay, now how are you feeling? We are feeling better now. Okay, so he felt, why they are asking such question? So something has happened in the night. Okay, and he must have overheard the doctor, the nurse, they were talking to the family member. So when he came to us, he asked me, something happened last night. Just anything happened in the last night? I asked why. So he said, I felt that something has happened last night, because the way my wife, my son was there with me, when the team came to visit me, they were talking also something, they were asking me such questions like how I felt, how I am feeling now, did I sleep well, did I have any dreams? They were asking me a lot of things. So I felt that there is something went wrong in the night. So I told him, yes, I would like to explain to you. Then I sat with him and I said, see, you were in severe pain. Remember when you came over here, we started the morphine. Morphine has a side effect of this one, to go into delirium. Okay. So I said, it was not a big thing. Okay, big thing in the sense, it is not that you had that, what to say, irrelevant talk, a disorientation, like this happened, you opened the door, you pushed your wife, removed your clothes and all. Okay, this happens when a patient is delirious. Same thing you also have done. Okay, but after that you were managed with that and now you're fine. Okay, so he was feeling very bad now. So I said, see, whatever has happened, that time you are not in conscious. Okay, you are not knowing what was happening. Okay, now you know you're conscious and your wife is also fine. Okay, of course, that time she also got scared, but she is also okay now. She understood why this happened. Okay, so I just told him all these things. Then he became little okay. So he said, okay. So then he was asking, then what? Of course, we reduced the dose for him, but still he was having pain. So we had to reduce the dose. But we made it a point that the next day also he needs to come to us. Okay. Apart from that, we had to find out whether he was what is hypoglycemic or hyponatremia, something like, but nothing was there like that. He had taken his food properly, everything was normal. So involvement in the management, we involved the family member also for the management. She was sitting next to me and she was hearing what I was talking to the patient. And whatever he was telling me, I was just listening to him. Then main thing is minimize the polypharmacy. If the patient is having a lot of drugs, please go through the drugs. Once I found with a patient, 3 colors of tramadol. Going to each clinic, what tramadol, ate all 3 tramadol because was not able to read it, saw the color, ate all 3 and came in good sleep. Family member said he is not getting up. Then I had to ask them, what is this? Doctor was educated. She said tramadol. I said, what is this tramadol? What is this tramadol? I said, 3 tramadol he has taken. Where is going to get up? So please go through the drugs, whatever they are taking. Tell them, whichever hospitals you are going, wherever you're going, whatever drugs you are having, please bring everything over here. Let us see. Go through all the drugs. Okay. And any medication used in the elderly, see that the medications are used, given properly, the doses are proper. Maintain good hydration and nourishment and ensure sufficient sleep. Sleep is one more thing. I saw a patient was so disturbed, that finally she got up and started walking. Family also got up. I was there, I also got up. Then she was all going to the near the door only. We opened the door, she went out and she was standing and looking up. Actually, what was happened? Just near to her window, to her bedroom window, there was a light on. Light means in the sense, it was really disturbing light and she couldn't sleep properly. Actually, she was not able to express it. So instead of that, she was not sleeping and she disturbed everyone. So we put off the light. She came inside and she slept. Sufficient sleep is also very important. I tell you, even we also, if you don't have sufficient sleep, we become delirious. I became delirious, I should say. It's simple in the sense that I should delirium in the sense I travel for more than 12 hours in the flight. Okay. By the time I finished my night duties, there were about 7 days continue night duty, daytime, no sleep, whole in the flight also I couldn't sleep properly. Okay. I landed in the airport and I was not knowing where I was. I walked somewhere in the airport. Okay. Somewhere I walked and then I saw I reached somewhere in a dark place. Okay. I was so sleepy. I was someone managing fully. In the sense, I can feel that I'm not in a proper place. I just came. My husband somehow managed me to pick me up, came to the room. That only I knew. Now the thing what has happened was when I got up, I was not knowing where I am. Because I was not knowing anything. Because my husband brought me inside, that much I remember. Then I went off. And that after that good sleep, when I got up, that sleep disturb was there. When I got up, I was thinking, what has happened? Where I am? I was all alone in the room. I got I was in fear, scared. After some time, I can see my husband. Then I came to my actual consciousness that I am with my husband in a place. It is not delirium, but still When we don't get proper sleep, you won't be able to do your work properly. This happens with the patient. If they don't have a proper sufficient sleep, they will become delirious. So we need to train the family member, communicate with the family member that the patient should have a sufficient sleep, good sleep, not much disturbance. That is very important. And of course, please teach them the terminal delirium also. And when the patients are in the terminal stage, they will have hallucinations, disorientation, irrelevant, so many things can happen. And why this will happen? Because they are slowly moving to death. If an elderly person is there at home, usually the elderly people, they know when death is approaching, this can happen. Okay. So if beforehand, if you anticipate these things and you can tell them that sometimes this can happen, at least they will be prepared. Otherwise, they will also get scared. During one of the Vishu, or one of the festival here, we were on duty. A patient was rushed with the children all in good new clothes. That man was talking something. He was disoriented, irrelevant. Okay. So we just put him on the bed. I just asked the family member. So they said, yeah, since past 3 days, he has not eaten anything. What we did, we drew the blood. We have for the investigation. We just started a saline. Okay, we sent the blood. It was hyponatremia. Okay, so just 1 or 2 questions. It was ready. We started. Another patient was in retention of urine. They said patient was talking irrelevantly. Patient was brought to the palliative care. When we saw, the bladder was full. Just took him, put a simple catheter, removed the urine, and there was a constipation. We did everything, and the patient was fine. Simple things that you can handle as a nurse. Only thing is you need to know how to do a physical examination and how to communicate. So early diagnosis and treatment is very important. Improved recognition of the condition. And of course, it is recommended that all acutely ill elderly patients should have a brief mental test on admission to increase the rate of detection of delirium, to find out whether the patient is okay or not. And of course, the environment modifications and close monitoring is very important. And remember one thing, please don't change the patient's bed every day. In the sense, bed in the sense the cot. Patient on first day 1, patient is in bed number 1. Day 2, patient is bed number 5. Day 5, the next day you're changing. Please don't change the patient. If the patient is put in one cot in one place, please keep the patients there. Please don't keep on changing the patient. That is one thing. Second thing, if a patient becomes delirious, please don't change the staffs also. If one person can look after that patient, that will be the best thing to do. And also allow the caregiver, I mean the family member who is looking after the patient, that same person should be with the patient. At least the patient will recognize that person. But if we keep on changing the people, more problems. So these things has to be kept in mind. If at all you want to restrain the patient, see that one hand is down, one arm down, and one arm up, and the head is raised. This is very important. It's not that both the hands are down, both the legs are kept like that. So see that it's properly restrained and don't keep for a long time. The non-pharmacological intervention, effective communication, and reorient. If the patient is first time coming to the hospital, orient them where they are. And if the patient was delirious and the patient becomes normal, reorient. Explaining where the person is, who they are, and what is their role. Promoting day activity. Okay, ask the family member if the patient can walk, to make the patient walk inside the house. If the patient is a bedridden patient, let them do their own daily activities, like keep all the things at the bedside for brushing, everything. Let them do, give them some paper to read, many things can be done. Okay. Maintaining a quiet and well-lit environment. A place, it is not dark, too dark and all. If a patient is in the daytime, see that the windows are kept open, the patient can read the newspaper, patient can look outside. Okay. Staff continuity, that is in the hospital, see that same person is looking after the patient. Avoiding room and bed changes, as I said, and providing hearing and visual aids. Okay. If they have a so using specs and visual aids, that also there. That also sometimes now for some time when delirious, when we don't get the specs, we see nothing. I cannot see anything. I cannot hear anything. Okay. So these things should be that these are the non-pharmacological intervention. Encouraging personal items, whatever they are using, their personal items should be encouraged for them to use it. Limiting visits, hyperactive delirium patient, please limit the visits. But in hypoactive, okay, see that someone comes and talks because the patient is hypoactive. Sometimes we will see, okay, let them sleep. But we need to find out actually what is going there. Okay. And remove anything that hurts the patients, like catheters, pumps are there, which is irritating to the patient, that we have to remove, and proper sleep. Interruptions of sleep should be minimized, and adequate nutrition. These are the main important things. This all I just kept. This is all for the memory. Some photos so that they can identify their children or their grandchildren or their wife, husband, whatever it is on the bedside. If you could all do these things, that will be better. Some bedside lamp, that is very important. Okay. So same thing, that's all. So it is told by Maya, I have learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. So remember that. Okay. They may forget everything, what you have said, what you have talked, but how you made them feel, that they will always remember. So with this, so any questions? We can take some questions.
Thank you, ma'am, for the excellent session. Anybody have any questions, please ask. Anybody?
Yeah, any questions is that you can ask, even ask, you can ask in any understanding language, I mean. You can put in the chat box also.
If you wants to talk in Hindi, you can talk.
Yeah.
Malayalam, Tamil, any language
you can ask. Anyone
Yeah.
wants to ask in Hindi also, you can ask. See, the causes like what I said, some tumors and these things now, that can happen. Main thing what you have to remember, what happens when they are in the hospital or at home. These things have to be explained to them. Simple things, say retention of urine, when there is an hyponatremia, and you know hyponatremia because the patient was on diuretic. So immediately we can do something. So these things has to be explained to the family, especially in a long-term diseases. This is very important. Financial problems cannot cause delirium, but of course, that fear, keep on thinking. They did not talk to them this one, I mean, did not share with anyone, it can cause. But financial loss itself cannot have a delirium. But suppose you think, you know that you are having a big debt, you have to give, you did not tell to your family member, no one knows, only you know. And what happens? You are piling up your fear. That anxiety increases, keep on increasing, and you will become delirious. That's what I said. Anxiety and fear can cause delirium. You know that maybe the bank people will come and tell that now we are going to this one, what to say? I'm not getting the word soon.
Bank notice, debt notice,
yeah,
right?
yeah, they will give the bank notice and all. They will say, yeah, now because you have not given the money back to the loan, you have not paid. Okay, so this will go to the court, and Sandy doesn't know what to do because he did not tell his family member. He will keep it in his mind only. He will think, oh my God, tomorrow what will happen to my family member? And thinking only, they will become delirious. And you know, many people, they commit suicide. You people must have come to, you have heard, na? And nowadays, bankrupt, suicide, loan they did not pay, committed suicide. So see, these are the things. So that is why when a patient is in a terminal illness, otherwise I think life-threatening illness and all, we talk, we tell in palliative care, not only physical, psychosocial, or spiritual, we talk about financial also. We ask how you are managing your house, about the education, children's this one, how they got married, any financial problem, this all we have to understand. At least we want them to ventilate their problems to us, not keeping it hiding, and finally they take a decision, I will die. So these things you have to, withdrawal of alcohol, of course. One day you must have seen the patient, people who are stopping alcohol, they will become delirious because they want that withdrawal symptom will be there. They want it. Okay, all these drug users also who are dependent to the drugs also. I've seen in Cochin, bigger than one place, and I have seen, of course, because I was in army, I know a lot of withdrawal cases used to come. Okay, that also can happen. Who are really alcoholic for a long time, and suddenly one day they take a decision, I'm going to stop. Okay, they will stop and they will start having these problems. When the drug users, I have seen, when they don't get the drug with the this one with the blade, they used to cut their hands and all. And that's what I said. We have to be very careful with such people, because aggressive behavior, they can even hurt us if they don't get. You must have heard, now nowadays we come across so many things. Children taking money from home and running out. Many things are happening. So what is this? Can withdrawal of alcohol? What is it?
Kanchav.
Kanjav, yeah. Very right. Kanjav, you read very fast. What I read is can have. What is this? Can have? See, Kanjav. Okay, yeah, that can happen because they don't get. They may do anything. This is what is happening nowadays. Even they will murder some people if they come to know, they are having some chain. They didn't get the chain. They will kill us. They will take because they want it. Something like that. No? They don't know what they are doing. What about family dispute? In the sense, again, Sister Jessie and Jessie Joseph, family dispute in the sense, the family dispute which gives me anxiety or sorrow. I don't know exactly. Okay, family dispute, whether it will cause delirium means, if you ask, if again, and then because of that family dispute, I have problems like fear, anxiety and all, day by day it goes, it can. But on another hand, if I think like a family dispute, something happens, patient can become depression also, a person. Isn't it, Shiba? They can become,
Yes.
you are asking depth. They can become
Yes.
depressed also. There's a family dispute. Because of that, I am not able to talk to my own family members, and slowly keeping these all things become depressed. That also can happen. But delirium, exactly, I don't know, until unless that gives you fear or something else, maybe. Depths, that's what I just now told. Financial problems can cause delirium. No, it cannot actually cause delirium. But of course, the fear of it may cause delirium. These all are just predisposing factors on this stuff. It is not exactly, we cannot tell. You must have heard now people who have financial problems and all, they act like this become psychiatric. Something happened to them. They ran out of the house and all. But we cannot say actual. So if there is not anything else, or we will close.
Yeah, I think we can go to the excellent session. So she has covered almost all the aspects of delirium. So I would like
Just one thing, actually, I did not talk much about the medications. Why, as nurses in India, we are not supposed to give our own medications. We know haloperidol, okay. Sometimes it is given 1 mg, 2 mg and all, but usually it is given according to doctor's orders. So that is why I didn't give the dosages, okay. But the drug of choice is haloperidol.
You should know what is the exact drug for managing delirium. This is the drug of choice is the haloperidol. So the another aspects, important aspects on delirium is, as we discussed earlier, the proper assessment. So because the most of the time the precipitating factors will be there. So Madam was mentioned in detail about that. So when a patients come to you with delirium, you have to assess properly whether there is any predisposing precipitating factors. Okay, like urinary retention, constipation, dehydration, these kind of things, unrelieved pain, these kind of things you can assess it properly, and based on your assessment, definitely in most of the palliative care settings, nurses will be doing the assessment part. So then only the doctor will see the patients. If possible, you have to assess well and make a note on it and give attention to the doctors, so that this patient is having constipation since last 7 days or something like that, or urinary retention. These kind of things you can get attention on that. So that doctors give more attention on that. Okay, so try to relieve the these kind of problems first, and then go for the non-pharmacological management. Try to relieve these symptoms with the non-pharmacological management first, and then go to the pharmacological management. And the another important aspects, the point is, if the patient is having delirium, the caregiver might be thinking like madness. So this is very, very important. You have to tell them they are okay. The patients, my loved one start mad. So these kind of things will be there. So you have to tell the caregivers first why the patients become delirious. So what is the exact cause of delirium? So we can able to control delirium. Most of the delirium are reversible, unless in end of life care. End of life care and the end stage delirium we can't reverse, but most of the time we can reverse. So these kind of things very, very important, especially without caregiver support, we can't do anything. So we need a proper guidance to the patients, caregivers in this delirium management. Okay, we can wind up. Ma'am, can we wind up?
Yeah, Shiva, we can wind up. Thank you so
Thank
much.
you.
Yeah,
Thank
I
you.
also have to go out also.
Oh, okay, ma'am. Okay, thank you.
Okay, thank you all participants very much. Okay, and see you all. Bye.
Thank you. Thank you. Bye. Bye-bye.
Bye, Shiva. And bye, Sini. Sini, I cannot say bye.
Hi, ma'am. Thank you.
Yeah, bye.
There.